So it looks like we're picking it up. All right, I'm going to go. Give me about 2 minutes. I'm going to get a cup of coffee here and move it upstairs and then into my quiet room. That's my new cat here. Here we go. There you go. It's a little kitten. So
Have you tested him for COVID,
yes,
Paul?
yes, absolutely. Yeah, it's well, I was going to say something that was going to be rude, so I'm just leaving it at that. All right, let me turn this off. I'm still on the line with the Florida guys. I'm going to tell them I'm getting off. I'll be right back. Mute.
While we're waiting, everyone, Jim Augustine, nice to see everybody again. Your IAFC, IAFF members, we had a lengthy call this morning about the current issues for the fire service. And everybody's wanting to get the vaccine programs up and running and be a participant in that, and that's good. We have asked the CDC for some definitive answers on things like, at what point after they get the vaccine does the quarantine process get modified, et cetera. So we will try to get some answers from the CDC that will help everybody. The IAFF is focused on the big four issues, which are masks around the station, good hand washing, stay away from sick people, don't come to work sick. That's their big four. And they have a really good interim after action report on the first part of COVID. And then everybody's concerned about what's going to happen with dry ice and moving stuff around the country. So the hazmat committee I meet with tomorrow for IFC to make sure that we distribute good cold chain management processes in case the containers get breached. That one of these things is going to get hijacked, and they're going to be concerned about that. So I'll get answers to people and distribute it amongst the Eagles. Thanks all of you for participating.
Jim, this is John Kramer. Just a quick follow-up to your comment about the vaccination issues. There are a number of entities and organizations that have approached the CDC. The working group has also been working on some vaccination issues. So we're hoping to get a small group conversation going, probably a meeting with the CDC in the very near future. I sent Paul an email about that earlier this morning, and obviously Eagles will be included in that. So more to follow, hopefully very soon.
Okay, thanks, John.
Hey, John Kramer, John Jew here. Do you happen to know, I can't remember that we've ever had this extensive cold chain distribution for vaccination. Have we ever done that as a nation?
Based on some conversations that I have heard, I don't believe so, which is why they're trying to be very deliberate about addressing it.
Yeah, as you know, the ultra cold is a huge issue operationally for us.
Yep, for sure.
Hey, and John, I do, in a sense, I've got those lists of names that you needed, people that are already involved with me. Unfortunately, had been Craig, but we also have routinely with the CDC had Jim Augustine on, John Jew, myself, Glenn Asada from New York, and we may add Peter, Ken Shepke is also involved. So I'll give you those list of names later so that you would have the proper invites, okay? So. All right, so
Thanks, Paul.
Okay, good. Yeah, so we got a pretty good quorum now. Let me see who all is here. Anybody have any limitations where they have to be off, for example, by 11 Eastern, 11 Central, 12 Eastern, by any chance?
Yeah, I got to be off by 9:30.
Who's that, Mark?
Yeah.
Okay, got it. Oh, by 9:30. Okay, so you got an hour.
An hour.
Yeah. Okay.
Paul, I need to drop off too, but I don't have any other updates today.
Okay, good. All right, thanks a lot then, John. And what time are you getting off?
11 your time.
Okay, so let's communicate later, but you have nothing to report at this point in time. Okay, good.
No, nothing new. Yep.
So this antigen thing might be interesting for you. We're going to go through, and there's some evolving practices there, and I think it's going to be kind of a cool thing to hear. And then next week should be pretty powerful. We are going to cover, I hope, the American Heart Association and European resuscitation guidelines that came out, and there's some things that I think we need to all regroup on here, because if we are responsible for what 50, 60 million Americans or more probably, then we have got to make sure that we got it right. If we can be locked in together, I don't care what guidelines they put out. And I've known that from history, even at the White House, where they went along with whatever we wanted to do. So that would be a really interesting counterpoint, I hope, next week that we'll try to accomplish. We'll also hear, I think, if I remember, Dr. Holman, Rob, that you have something you were going to try to talk about next week, right? What was that about?
Yes, about our experience with the nurse triage line.
Okay, got it. Okay, cool. And it just as a highlight on that, what specifically about that?
I just want to show our build out and our data so far.
Yeah, I mean, what I guess I meant to ask you was, what does that purpose do? They're in dispatch, and what do they do? Triage there, or do they triage them to alternate sites, or what's the function?
So what we have is we have the nurses in the 911 system that take low acuity callers and then hook them up with transportation to alternative destinations.
Yeah. Okay, so that's what I was getting at. So I look forward to hearing what you guys have found so far in the nation's capital, 70 square miles surrounded by reality. So, all right, let's move on.
Yeah.
Hey, Scott, since we don't get to see you much because of the dates, I want to know, of all the people, we got a pretty good quorum. Let me see what the numbers are right now, 36. So I was going to wait till we got over to 40, but what I was going to say was, let's see, who had to be up by 9:32? Joel. Okay, got it. What I wanted to do was see how people would be if I also ran this on Wednesday or did Wednesday as an alternative. Is that a problem for most of the people? Let's say if we did the same time tomorrow, and I might even do it again tomorrow. We'll see for ours, because there's some people that are overseas that wanted to get on, but Tuesday evenings seem to be bad for them because they have meetings with, like, say, the ministers of health in their countries, that kind of thing. So does anybody have a problem with Wednesday at this time?
We've got resident conferences in Utah.
Okay. Anybody else?
Yeah, I have all my conferences, which I have to attend as well. That's our educational day in Portland.
What if I did it on Thursday? Is that a same
Better.
problem? Huh?
Thursday's good for me.
Okay. Anybody else?
Thursday's good for me.
Thursdays
Okay.
when we have all our educational conferences in Minneapolis.
Okay.
Okay, in Minneapolis. Okay, got it. I guess we'll never find anything. The other thing is we could do an alternating dates, or 2 dates a week. Is another possibility, because this has always been a good kind. I think we're going to pick up a lot on data and presentations here in the next little while, so we'll see. How about Friday then? Because we used to do Tuesday, Friday. Anybody have problems on Fridays? So maybe Friday is the day. I'll have to ask my people over in Perth and Singapore and so on and see what they think about that. So, because when we did that, that used to be a good date for them, etc. All righty. So let me see who else is on here that I need to get to. Well, since I got you on the phone, Joelle, and you got to get off soon, anything to report from your end?
Nothing big. We had our first round of asymptomatic surveillance, or we're undergoing our first round of asymptomatic COVID surveillance testing. We did a first round as this study trial, and now we're actually doing periodic surveillance testing, I think about quarterly. So this is our first time. And as we progress and get data, we'll let you know how it goes.
And who are you surveilling?
We are, the city of San Diego Fire Rescue paramedics and actually, let me start that again. All employees with San Diego Fire Rescue, our dispatchers and civilians associated with fire are invited voluntarily to participate in Interior NAR's PCR testing. Yeah. It's with the same lab who's doing the return to learn surveillance testing with UCSD.
Yeah. So I think it's not the general public, but that's why I wanted to ask you.
It's not. No. We are swabbing ourselves and submit. Like, we pick up the supplies from the lab in the morning, swab ourselves, and then submit them in the evening.
Yeah. The reason why I was asking is that couple days ago, I got the early edition of the New England Journal, and I think it came out yesterday, that the Iceland folks did a really great surveillance looking at PCR and antibody testing, and they had actually a brighter outlook on the antibody testing, but they did a whole slew of different ones, different kinds, and but might be very interesting for you to see what they found out there. Okay.
Yeah, I'll look at that. Thanks, Paul.
Yeah. Okay. Good. And if I get a chance, I'll try to send you a copy. But it's I wonder if I have it right here back. Nope, I left it downstairs. Sorry. But yeah, just look it up. There's both a nice editorial that was very positive about antibodies because we've all been negative about it, and then the article it's responding to the Icelandic stuff. They did a great job there in Iceland, so it's kind of cool. All right, so thank
We're
you.
starting with the PCR, but we have on the agenda possibly antibody and possible antigen testing. Where this is just the one that was easiest to get through.
Yep. Okay, got it.
I'm going to do that in Salt Lake, Paul, with the antigen testing. We're going to start testing platoons as they arrive for work. It's a 15-minute turnaround times. We're having a lot.
Yeah, which test are you using?
It's the Abbott antigen test. So I'm told it's good for mass screening, and results need to be confirmed with PCR, but it's a way of screening the platoons as they come in, so we don't have what's going on now is day 2 of a shift, somebody comes down with a fever, and now we've got the entire platoon exposed because we can't get everybody to wear masks and physically distance in the station like they should. We've encouraged it, but it hasn't been mandated from the top.
Okay, got it. Well, the reason why I'm bringing this up is that we've been discussing exactly what you're talking about. About doing antigen. In fact, we're going to have a presentation by John Jew in just a few minutes to catch up on this, and then hopefully Peter can add in a little bit more because he's doing another. He's using, I don't know if you guys got the talk, but he's using a different what's the word, product, manufacturer. And so it's going to be interesting to see all the contrast and see how this will come up. It may end up being that antigen and some early new PCRs that are coming out, the combination may be a good way of going is my guess, but I have to be, that has to be proven. And I like to see what we have to say here. Okay, I'm trying to see who else had to get off, but let me talk to Scott because we haven't talked to Scott out Salt Lake for a while. Can you tell us, all I hear this morning on the news, yesterday evening, is that, your hospitals are really being pretty overwhelmed and the cases are going up even further. And so you'll probably have more deaths in about a month. And so is it just being exaggerated by the media, or are things really looking pretty tight for you, both in the hospital as well as, out of hospital?
It's looking pretty tight in hospital. The pre-hospital providers aren't overwhelmed. I think we're still down on usual traffic by about 10%. So it's not been too bad. The hospitals, though, are real tight. We're bumping up against capacity, even though we've expanded capacity, both ICU beds and ward beds that are dedicated to COVID patients. So it's getting hot.
I heard you opened what I was going to say was I heard that they're opening up like a 5th new wing, a converted wing today at the University Hospital. So so that's what I'm saying. So it's the real thing, huh? Okay.
Yeah. So the MICU people are real exhausted, and I've heard morale is pretty low. I live pretty close to one of the pulmonary critical care guys here in Salt Lake.
Yeah. So that leads me actually to a thing. I don't know if you all got the message, or Jim can send it out further. I just sent something, Jim, about the theater of war tonight, ASAP, and the whole issue about crisis coping, moral resistance, as we're not resilience as we're calling it, has become a big topic for them. And I was actually able to get us all invited. So Sandy Schneider, who couldn't make it today because she is helping to run ASAP, sent us a link where we could all plug in and watch Theater of War tonight. And it's great because a couple of my friends are going to be on. Catherine Irby, you guys know from what is that called? Law and Order, Criminal Intent. She's been on forever on that thing. I remember seeing her the first time in a session called The Good Doctor back in just after 9/11. And I think, Jesse Eisenberg, who you guys know from, the Social Network and all those kinds of things, and Zombieland, I think. And then also Frankie Fazzone, who's been known for The Wire and a bunch of things. But my dear friend David Strathern is going to be on, and he's just terrific. And they're going to do a Greek tragedy, and you're going to see how it really relates to the stuff that we are doing today. Let's see who's calling me now. But anyway, so the link is there, so you might want to take a look at it. This can be one of those BS calls, I'm sure. Go ahead. What is your emergency? Here we go. It's a public message. Okay. All right. So any event, I think that's going to be a cool thing to check out tonight. It's going to be on Central Time at 7 p.m. So that would be 8 p.m. Eastern. And, you can do the rest of the calculations for other parts of the country. But it's really kind of a cool thing. I had Craig Manifold actually view it for me and a couple other people to see, should we run it at Eagles? And he got off and said, absolutely, this is really great. And then I had talked to you guys about it, and Sandy was on, and she was intrigued. They watched some of the things that people there at ASAP, and they said, this is great. We're going to bring it in. So it's a little eclectic. You got to have some level of interest of literature and have some intellectual content there. But also, I think it's kind of cool to see that the same issues were going on, a couple thousand years ago. And more importantly, if you have your open mind and what they've learned, because he's done over 1,500 productions with military through the DoD, which means it's been really well accepted. Even the chief of staffs have attended it and really supported it. That the more open-minded you are about, the better it is for you. And they said the people who are the most resistant may have the most problems. And so it's a kind of an interesting twist. And so I think it'd be interesting for you to see tonight. All right, so we'll try to make sure it's set. Jim, did you get the last link for me for that Sandy's message that I got at 10 o'clock today?
Yes, I did. And I'll distribute it out across the wide group.
Okay, good. Fantastic. Okay, good. All right, anybody else have anything burning to report before I move into the formal presentation by John? If not, I will then move on and all that. Hey, Kathy, just since we haven't had you on for a while, before we go any further, anything going on in New Hampshire? What's happening up there? I don't know if you can hear me or not. Kathy Clem, I don't know if we caught you off guard or not. Or yeah, so may have caught her off guard. We'll see. We'll get back to her later on. Okay, so let's go ahead, John, if you don't mind, let's go ahead and make your presentation on antigens. I think this is going to be kind of interesting from a lot of point of views because there are obviously limitations, but they also may have some advantages. And I think I want to hear what John's been doing a great job on keeping up the literature, and we've been talking about this over the last few weeks, so we want to see what happens here. Okay, so there you go.
Can you see my slide, Paul, just to confirm?
Yeah, I can. And then let me make one quick announcement. Okay. For those of you who are paying attention for the first time, or you're going to be watching this recording later with EMS World or wherever, or all others, keep in mind, this is the gathering of the Eagles, so to speak, the jurisdictional medical directors from a lot of the metropolitan cities around the world, mostly the United States. And this is all being recorded, and it goes out for public, public use as well. And so our first speaker will be Dr. John Jew. Dr. Jew is, of course, the medical director for his county and surrounding Portland, Oregon. And he's also the medical director of the state police there in Oregon, and has been on this job for a quarter century. And is also an infectious disease specialist, boarded in infectious disease. And it's been one of our contributing editors along here with Dr. Holman in this area. And then later, Peter, I want to make sure you bring up your issues, especially if John doesn't cover it all. Okay, so let's go on, and John, hit it.
All right, thank you, Paul. I've got about 17 slides, but most of them are easy to follow here. We're really going to confine our topic to the COVID-2 antigen test here as well. So before we go too far off the grid here, I just need to identify what is the COVID antigen test versus the PCR. As everybody knows, the PCR looks at the RNA literally and actually can basically distinguish between the various, I think it's now 7 coronaviruses that are in the wild that affect humans here as well. But the antigen test looks at the nuclear capsid outlined in blue. And the only real reason I'm bringing this up is that the false positives are probably related to the nuclear capsid and the shared domain with the other coronaviruses here as well. So the possibility of a false positive is significantly, well, significantly is my term, is higher than obviously a PCR, which is rarely false positive here as well. So let's go into the current tests that are out there right now. This is accurate as of yesterday, and there are basically 6 coronavirus antigen tests that are on the market. Of the 6, the newest one are the Access Bio, as you can sort of see. I'm not sure if you can see my counter here, and this is a one that just got approved on the 13th of October. More importantly is the Quidel Sophia 2 flu and SARS antigen FIA, which is actually the quote unquote sweet spot where as we go into the flu season, you can get only one swab and actually do this here as well. If you notice the technology, almost all of them are lateral flow technology. That's just a complete topic in itself, but basically it's an office test that doesn't require a lot of instrumentation. And of the 6, I believe the only one that's really easy to use, I could be wrong, is the Binax Now. In other words, you don't need an instrument for that to occur. So this is really what's currently on the market under the FDA EU agreement here as well. The other issue that I need to point out to everybody on this call right now is that the EUA is for symptomatic patients here as well. And so if you look at the EUA, what's identified in the right-hand column is any days since the onset here as well. So there are 2 points. One of them is the EUA was looking at the only symptomatic patients. And the second one is that there's a window of opportunity on symptomatic patients, as you can sort of see here. Most of us are using 5 to 7 days, and sometimes it's really hard to know when they got expected. But again, what I'd like to emphasize is the fact that almost all the EUAs are from symptomatic patients. That's not to say we shouldn't use it in asymptomatic patients, but I'd like to highlight that the data is not there here as well. And so this is the Sophia flu SARS antigen FIA. There's a lot of data and gave me a headache when I looked at it. But basically, it's a sandwich assay looking at the flu virus, both A and B, as well as the COVID-2 antigen here as well. There are numbers, if you can sort of see, there are 2 highlights. One of them is that according to their Quidel, which is there are 0 false positive. The false negatives we can deal with fairly easily because we get false negatives as well in our PCR tests here as well. It's the false positive that causes me to sort of be concerned when I have to figure out what to do with them here as well. This is the newest antigen test, CareStart COVID antigen here as well. And you can sort of see, again, their results are pretty good, where they have no false negatives as well. I'm going to go through these fairly quickly and summarize where you are at. And again, the potential false positive cautions here. Some of the times a false positive, you can assume it's false positive, but if you're actually trying to treat a patient or actually move a patient to a cohorted area like a nursing home, I would suggest you need to confirm that with a PCR test here as well. But those are areas that we need to identify as a community, both infectious disease as well as EMS community here as well. So the false positives are pretty easy, well, actually harder to figure out what to do than the false negative. False negatives, you can probably just retest until you get it as well. What I like to highlight on this slide here is that a lot of them are requiring a special device office device, but still a device. And only, I believe, the Binax Now does not require a device, but almost all the time it's a colorimetric lateral flow where you look at it's like a pregnancy test that we're all used to here as well. The Binax Now actually has an app, I believe, and there's some others that have an app that shows you the results here as well. So this is the Binax Now. You can say, that's not really much here as well, but if you actually do thousands of tests, that's significantly an issue here as well. So a false positive, again, is a concern here as well. So all of them have some sort of false negatives and false positives. But I think if you look at the EUA, you need to look at two things. Number one, the number of samples, and number two, number of false positives and false negatives here. And I'll send this out to the groups that you can actually look at, because looking at tables when you're in a presentation sometimes is hard here as well. So this is Illumina. Again, this is it's a UK firm. There's a very high percentage of false positive here on Illumina, but the PCR test was false negative here as well. And the final slide is Costco is advertising a PCR COVID-19 test for $129, and it's a saliva test based upon the Yale saliva EUA that they got earlier in September here as well. So I'm going to turn it back to Paul and take questions if you have it.
Yeah, okay. I think the things to point out that the EUAs, just the big picture, EUAs are based on very small numbers in a way, which is like, why is that? Okay, in some respects, it'd be nice to get it, further tested and getting more reporting back. That's number one. Number two is the issue that this has only been issued for symptomatic patients. So that'll become very interesting to see how many people are antigen positive, even though they may be asymptomatic. And I think that might be an interesting thing to see, because people are thinking about using this for work. They're thinking about using it to get into, let's say, a mass gathering. There's all those things that are warming up and percolating up, or when they're doing the bubbles at the various professional sports events, etc. Peter, you've done actually 1,000 patients or so far looking at this, and I don't know if you chose just symptomatic patients or asymptomatic as well. What did you find out? Can you give us a quick rundown, or is it too early because you had a report to the FDA?
Yeah, so and it's actually not, now that I've kind of been through the process twice, which is the second FDA submission, is with this particular test, we only submitted the patients who were either from day 0 to day 9. Now, we basically tested every person consecutively at 3 sites in Palm Beach County. So we had over 1,200, but we had a lot of people coming back for repeat testing. And so once you kind of filter out all those people, the FDA wants to see that first 10 days. And so out of the 1,200, we ended up having, and I have the numbers here in front of me, hold on. We ended up having a total of 202 submissions. And we had a 94.3% sensitivity. Like John had mentioned, we did have 2 false positives out of the 202, and our specificity was 98.7. So, and just by the way, with the antibody submission that we had, the FDA did a full review, and they had done their own evaluation at the National Cancer Institute. Here, they're not doing that. They're just basically saying, and we're submitting all the positive PCR reports and so forth. That's the first thing I wanted to mention. The second thing is, if you read the EUA itself, it states that you have to have a CLIA certificate of waiver. That means you have to apply for a CLIA certificate of waiver. So for all of the folks out there who plan on doing these antigen tests, I'd go to the website, and I'll put the link here in the chat in a minute. But you basically have to fill out a 2-page application, and then you have to kind of get certified that you're going to be using these tests under the CLIA certificate of waiver platform. So I think that's the second one. And then just to reiterate, there's currently 2 of these devices that do not require a machine: the Access Bio, which is the one that just got it approved, and the Abbott Binax Now. And then the one that I'm submitting would be the third one. So, and just to go back to Scott's comment and to reiterate what John just said, is that right, these tests, all this data is not really meant for everybody for the screening. However, I'm sure that people are going to be using it in that manner, but just understand that this data is not looking at everybody. It's looking at a very small portion of the population that we're testing.
Okay, got it. Well, thanks so much. And then the other thing, Peter, I think, if you look back at the note that we got from Scott, he said they are doing their test with CLIA waiver. That's an excellent third point that I forgot to leave out. So thanks for capturing that as well.
Right, but normally, Paul, normally a CLIA waive test means that it's CLIA waive, but you have to get that certificate. So I'm going to put that application in the chat right now.
Yeah, good. Thought I saw Jose Cabanas on earlier. Are you still there, Jose, by any chance? Apparently not. Okay, so
Yeah, Paul, this is Brent. He had to step out for another meeting with the county, but he said I could text him if you need him back.
Well, I just wanted to congratulate him. That's all in front of the group. That's all. Or I should say, send our condolences, which would be really cool. But I'll come back to this. So meanwhile, let me say at this point, does anybody have any questions for either John or for Peter regarding this? I hope this was interesting for you anyways. Okay. So if not, I do want to remind everybody, since I got most of the people on the phone still, that you're going to get CME credit for you if you want to claim it. Going through that cloud CME, whatever it was for MHS. I don't know if I have the link right now, but most of you should have had it from before. And today's code to put in is 11938, 11938. It says I got a thing that says I emailed to the list. We'll try to get on. The people, Candace, who's been helping us with that, says she'll try to get on later. But just for now, if you need to know the code and you want to claim your CME 1.5 hours after this, it's 119, so 11938. It's interesting because I've been keeping track of this. Is that it's gone from it's even numbers. It started at 11/19/28, then 11/19/30, 11/19/32. So now last week was 11/19/36. So if you forget the number, I'm just telling you, go back to what you had before if you want. But I think this got set out to you already. All right. Well, thanks a lot, John. Then that was a really great, catch up. So if you were to, let me just ask you this now, this is totally kind of off the record, just asking as a friend informally, if you wanted to hold an event and you wanted to test people, what would you do? What would do you have any one of these things that looks interesting to you, or do you try 2 or 3 of them at the same time, or would you do PCR and antigen? Let's say if it was a back to work or going to an event, I don't know, just something in the future.
Yeah, that's a great question. Don't get my presentation wrong. In other words, I think the rapid tests are a breakthrough, but we just need to be careful on what the science shows us here as well. I think there will be data on asymptomatic. The direct answer to your question is I would use a rapid test to actually identify I would say high risk individuals, but keep aware that the false negative is significant as well as even the false positive. Rumor has it, and it's confirmed rumor, that the White House was using the Binax Now. And you saw what happened with the White House as well. I have to be careful how I say this. The other one is that you saw what happened with the Ohio governor who had a false positive and turned out to be a false negative. He was using a Quidel test here as well. So I think all of us as medical providers, if we know the limitation of the test, we can apply it in a very intelligent fashion. So I believe a combination of the PCR test as well as the rapid lateral flow test is probably the way to go, because we need to really increase our turnaround time and narrow our scope of attention to the people that we want to pay attention to. Again, if you want to do a large gathering, you should not assume that everybody that's negative, which is really the false assumption here. Back to you, Paul.
Well, and I don't think it's political to discuss. You give us the facts of the case, what they were using at the White House, and what did they find? Did they say that it was negative using that, and then it turned out the person actually had the disease? Or I wasn't following what you were saying there. I don't think that's
yeah. In other words, I'll send you the article, but I think it was either JAMA or New England Journal article that actually points the fact that the White House was using the Binax Now as well. Okay.
Yeah. I get that, but what did they find? I mean,
it's obviously they found false negatives here.
Got it. Okay.
Yeah.
Okay. Got it.
All right. Yeah, Paul. The comment I'll make, and the way that I feel about these now, is that when these tests hit positive, I feel very good about the result. But when the test comes back negative, I don't really kind of hold my hat on that and say that that's a negative test. And if people have a very solid exposure, I'm still having those people go in quarantine, and then we're going to be retesting them. So I do agree that you have to have a backup, just like the antibody test that we did. You have to have a backup, and I think the backup's still going to remain the PCR. But there are a lot of people out there, Paul, as you know, because you've been involved in these conversations, the entertainment industry, the airlines, they're all looking at a more rapid on-site test, either to get people back on the airplane safely or to get people back into the theater safely. So I'm on 3-4 conference calls a week with these major organizations, and a lot of people are going to be using these tests probably incorrectly, and we're going to be seeing outbreaks because of them. But I think it's better than what we've had.
Yeah, one other comment is I agree with Peter completely. If you actually have a cohort like an NFL or national basketball league where you actually have a small cohort like a fire department, if you do continual surveillance, you're going to pick them up as well. So I think that's a completely different thing. So a one-time assay versus a continuous sampling are
Yes.
two different models.
That's a great point. 100%. Paul, you're on mute.
Just had someone walk into my area here. So anyways, Dustin, why don't you go ahead and elaborate a little bit more on the background story on the Ohio governor. Just for those who don't know, why don't you say what's the background and what happened, and give us the twist from your end. And COVID karma to you too, Joe Holly. Go ahead.
Sure, Dr. Rebbe. So Ohio has been pretty aggressive with nursing facilities, and now have some nursing facilities on a once or even twice weekly testing regimen based on various characteristics of their region. At the very beginning of that, right as they announced the scheme for frequency of nursing facility testing, one of the solutions they said was, we understand this is hard. Here's how we're going to help solve it. We're going to send you a bunch of these machines that are going to be rapid testing, antigen testing for you. And then 2 days later, I think it was 2, maybe 3, this false positive for the governor comes out, and it's discovered that it's the same machine. So obviously, scientifically, that doesn't matter, but it caused us some pretty big PR problems with getting the nursing facilities and their patients and family members to be comfortable with it. So it's just an interesting quirk of how the complexities of this are hard enough for us to understand, and they can really cause a problem when they get into the media.
So what happened was, how did they determine that the governor's was actually a false positive? So he turned positive. They said, he's exposed, but was it a PCR? Was it a?
I believe, yeah, they retested in PCR.
Okay, but the question is, could have been possible that he was positive, and then later on he was negative, because it's easy to become negative pretty quickly on these tests. You got to catch people at the right window. How did they come to the conclusion that he wasn't sick? Is there
typically the PCRs don't turn back positive quickly. It's the antigens that can after that time window. So usually with the PCRs, those are the ones that we're seeing run really long positive. So when they found his PCR to be negative, that was when they determined that his antigen must have been a false positive.
Got it. Hey, and then John, real quickly, what's your reaction to that? Do you agree with that? Or do you have any other caveats?
I agree with that. Well, actually, there's actually a continued issue. The false negatives could be, there's a continued scientific debate among the laboratorians that if you get a cyclic threshold value on a PCR test like above 30 or 35, that you're not infectious. I'm not sure if I agree with that, but if you actually look at the lateral flow assays, they're going to turn positive with a cyclic threshold less than 20, which is usually very high as well. So I think we need to be a little aware of the limitations of the test, and as well as the infectivity of the virus.
Okay. Hey, next week, John, if you don't mind, the study that just came out in Iceland talking about antibody testing. I just made a presentation yesterday for ACEP on, I think I've probably reported that from Peter and Meg and I and Ken about how the younger people don't turn antibody positive, ironically, especially if it's a milder disease. And it turned out that was the case with MERS. And it turned out that's what they found in Iceland too, although there's so much stuff in that paper, it's so technical that I had a hard time getting through that. But I'd like to see your opinion about that, and maybe we can present, Meg and I can present the study we did on the younger people not turning antibody positive next week as well. We'll have an antibody week next week. Okay, would that be?
Yeah, sure. For everybody on the call, Nature Medicine just published a UK study, which is the longest, best cohort study on antibodies. It's well done because they looked at neutralizing antibodies and basically validated a lot of your observations, Paul and Megan as well. So there's a group, if you've got serious infection, you obviously had an antibody. If you didn't have serious infection, sometimes you didn't mount an antibody, but they looked at basically survivors of COVID for 90 days plus here as well. And all the titers sort of went down as well.
Yeah, and so, and as Ken's pointed out, it may be that if you send in the Air Force early on and just have a strafe bombing, so to speak, with killer T cells, then maybe you don't need to have humoral antibody production. So it's all kind of interesting stuff, and it's just paradoxical in some respects that the young people don't make the antibodies and all that. I actually found out yesterday, I went and got my flu shot per Dr. Osterholm's recommendation to do it towards the end of the month of October, and they gave me it's like, I don't know if it's a double dose, but they said anybody over 65 gets a higher dose versus what other people are getting the flu shot. Have you heard that? And is there any data for that to support that, John, and or Rob, if you're on? Yes.
Repeat that question, Paul. I missed it.
Oh, yesterday I got my flu shot, and they
Yeah.
told me that because I was over 65, that I had a higher dose. I don't know if it's a double dose.
Yeah, in other words, it's I think at least 4 times the dose here as well. But
Yeah.
you're not a normal over 65 years, nor am I as well. So, but I think the question is, there's very clear data that the older you are, the less you mount the immunity here as well. And there's waning immunity to the flu shot, by the way. And I think Mike Osterholm, he actually said it. He actually gets his flu shot late to time with the flu in Minnesota as well.
Right. And that's why I always follow. He usually tells me to do towards the end of October, early November. And Rob, you were going to say something. I cut you off.
No, I was just holding 4. It's 4 times.
Yeah.
Okay. The dose.
So I was correct.
There's good data for it. I know that people have being immunity older because it show you that does protect you, and they don't have. Do they have any kind of side effects from getting that higher dose?
Sore arm.
Okay. So I got past the sore arm part. Right. That's good. All right. Well, then let's do that next week. Rob, you'll do your thing on the dispatch, and then you can also comment on these issues. And so, John, do the antibody from Iceland and Nature, and Meg and I will do our thing on our study, just to show, because I could actually just launch the presentation I made, Meg, I think, and we can comment on it later on. Okay. All right. So, hey, Darren, I don't know if you could get on Murphy from Ireland. I thought maybe if you wouldn't mind talking, hearing what's the latest there, because I know things are getting rough in Europe. It looks like our other European friends, and I talked to them within the last 2 days, and they were fairly over swamped, particularly in Paris right now. But Darren, I don't know if you can hear me or not. Murphy from Dublin, can you get on?
Paul. Greetings from Kildare.
Yeah. So
we're
at
level.
Your neck of the woods. Go ahead. I'm sorry.
We're in a level 5, which is the highest level. So it's as close to a kind of proper lockdown as we've had since the start of this. We've been at this since last Wednesday, and it's gone for 6 weeks. We've had numbers that have kind of topped 1,200 per day. Over the last few weeks, they've started to come back down again because Dublin was first at level 3, and then the rest of the country was in level 3 before we all ended up in level 5. And the numbers just kept on going up and up and up. So they're starting to show some signs of coming back down. However, like it's very, very soon to know. But the whole idea of this is to make sure that we can that businesses and the country as a whole will be back on track for Christmas. That's kind of the aim at the moment. But there's a little bit of fatigue here with people kind of not really paying attention. Whereas I think this level 5 now has kind of jolted everybody into paying attention to it. So hopefully.
I gotta make I don't want to make too much of a stereotypical claim here, but was it people going to bars and so on, or is it just lax at home, or what do you think it was?
Well, the bars, or as they call them, wet bars, the wet bars and they're bars that don't serve any food, haven't been open in Dublin since March. They only recently opened in the rest of the country, probably, would have been the middle of September, I think. So they were only open for a couple of weeks. They reckon it was, look, I don't know. Nobody's really know. It was kind of, the schools are all open now, but they're saying that the schools aren't where this is coming from. This is all kind of community based. I personally, and again, I'm not a medical person, so I can only make a kind of an observation. People were starting to get fatigued. People weren't paying attention so much to the social distancing. Masks were being worn all right, but look, I just don't think people were paying that much attention to it, and it came back to bite us. So.
Yeah, my guess is, and just my social observations are that, I mean, I see it amongst myself. It is like getting kind of old, and where I used to be very compulsive myself, like if I took a credit card from somebody and then I would immediately wash my hands, wash the credit card and all that, and I'm doing less of that, and because I don't know if that makes a difference, but then again, if you let your guard down just once, like Chris Christie did when he was he said he had been using masks all along, and then when he went in and met with the president, he took it off, and he regrets that. So I think that keeping our guard down. I'm wondering if we will get a secondary positive effect, especially with the flu, with everybody being worried that they are getting their flu shots, they're masking, they're doing better hygiene in general, especially the older people, and that maybe we won't get hit as hard with flu. I just can only hope, that kind of thing. But it's just a shame because how's things economically as a result of the shutdown?
There's some businesses that they don't think will open up again. A lot of the kind of service businesses like, beauty salons, hair salons, barbers, that kind of stuff, really got a kicking at the start. They kind of got back open again. The pubs were really hit badly. Obviously the wet bars in particular. And they were open for a couple of weeks and they were closed back down again. So I think that's going to have a huge effect on the economy of it. Obviously, personally, the fact that there's no gigs, there's no events is a huge thing for me personally. Obviously, that's, hopefully we can get back on track and get a few gigs going. But again, it's just not safe to do it. So people are feeling it.
Well, thanks for letting me take advantage of you. Thanks for joining us too. It's great to see it. Really great to see. I'll call you later this week if you don't mind. Okay. So.
Yeah, that'd be great. Thanks for the invite.
That's to you and the kids. I'm trying to think. Jose Cabanas, I think you're on the line with us. I don't know if you are, or you can join us real quickly. Yeah, we just wanted to extend our deepest condolences to you for your election as the next coming president of the NAEMSP and all that. And so we just want to know, are you going to be supportive of, are you going to support the Obamacare, or are you going to, no, actually, so it's really kind of cool, but did you actually have some kind of, things that you want to propose that you're going to do for NAMSP, or is it just going to be one of those things where you're just going to go along and be president for a year, for 2 years, right? 2 years.
Well, no, I appreciate the correlations, Paul, and the rest of the team. Sorry, I'm in another conference call, and that's why I'm late to this one. No, thanks so much. Certainly, my plan is to keep on going the efforts that MSP has continued to push forward, and the advocacy fund and all the other things that are matter to our specialty. So we're going to keep moving those initiatives moving forward. So definitely we'll be very busy. So now kind of, as you know, the hard work starts pretty soon. So.
Yeah. So are you going to raise taxes, or?
We may raise your taxes, Paul. How about that?
I think that happened already. So, okay, good. Well, listen, thank you so much. Anyways, we just wanted to say it's cool that one of our members got, and also I heard that one of our members at large positions is for Sophia as well.
Yeah,
so in Boston.
Sophia was going to be serving as member at large, and Dr. Gallagher got reelected, and Sabina's going to be secretary treasurer. So that's you know, a lot of good energy in the board and a lot of good teams. So we're gonna just keep pushing forward those things that really matter to our specialty. So.
Yeah. And then it's really cool. And then in terms of Eagles, I think also we got Mike Levy coming in as the president-elect, that kind of thing. So,
yeah.
So, hey, Brent, I see you're over there. Hey, Brent Myers. Okay. So does this look like we're all going downhill over NMSP? You've been the president in the past, right?
You know, it's an interesting group of folks that have gone through that in the past 4 years, that's for sure. But no,
Yeah.
I think we're in really good shape.
Yeah, that's good.
We are the PAC was we're giving out our last donations of the election season. It's an amazing thing. Actually, this is the first year we've been fully functioning with the PAC for 2 years for the full election cycle. So those are always interesting.
Good for you guys. Okay, good. Well, anyways, we just wanted to say hello and thank you and congratulations to Jose, and really appreciate as usual, best to your bride. Okay, so which is she's your better 90%. So okay, hey, and then hey Brent, while I got you on the phone, anything new happening in the ketamine siege by any chance?
There is you will see probably later today or tomorrow a link for next Friday. There will be an NAMSP webinar devoted to ketamine and sedation. We're looking at the first draft of a new position paper that'll be coming out, as well as reviewing data that have been accepted for the national meeting. So look for an invitation. I think it's at noon Eastern or 1 Eastern next Friday. Don't quote me on that, but it's one of the two. But yeah, that'll be coming out very, very shortly.
Okay, good. All right, good. And we heard anything about the 60 Minutes thing yet?
We have not, and we know that the governor of Colorado seems to be, and I think Stein is on this call, but it looks like they're going at a 2-week kind of every meeting every 2 weeks and kind of slowing the roll there just a little bit, which is good news for us. That I think that gives time for a little cooler heads to maybe prevail.
Okay, got it. Okay, good. Anything to add to that, Stein?
Yeah, so the update is right along with what was just mentioned, and it is slowing down a little bit. The state has now incorporated, as of like 2 days ago, has incorporated an EMS physician, that a board certified EMS physician who I can't name, but is one of the Eagles and is not me, from Colorado, to be part of the review board on this issue. So that's a huge step forward, and probably a lot due to the position statements and the pressures that were put both locally and nationally. So we'll expect some updates in the next few weeks.
All right, good. Hey, so Chuck Mason, I've been bugging you to get on with us. And so thank you for taking the time to join us, if you don't mind, from Little Rock. And so I know you've been really busy. This is a time what's bad for you. So let's take advantage of the fact that you're here. Anything you could report to us in general that's been going on with you in Little Rock with your EMS? And it doesn't have to be COVID related, it could be anything. So we wanted to just catch up with you. Nope, maybe lost Chuck. He is busy on Tuesday mornings, that's all. Are you still muted, Chuck? Or are you there still? Okay, well, that's unfortunate. Oh, are you there?
Yeah, did that work?
Yeah, Chuck, are you there?
Is it not working?
Is that you talking right now, saying not working? Hey, Chuck, go ahead. Are you there? I see ya. Okay.
Yeah, Chuck, you just muted yourself again. Bottom left corner, unmute yourself.
Unmute.
There you
Did
go.
that work?
There you go.
Sorry about that. Yeah, unfortunately, most Tuesdays I'm stuck in the department working a shift, but our system's working fairly well. We've had very little problem with COVID. I think we've had a total of 12 out of 400 paramedics here come down with COVID, and all of them have gotten them socially outside the deployment. We've done pretty well. I can complain. The hospital actually does the Sophia 2 test. We do almost over 120 tests a day, kind of a drive-through like range. I think we have about a 20% positive right now for the Sophia 2 here in Arkansas. We're seeing quite a bit.
Okay. Overall, you've got Little Rock and a lot of surrounding territories as well that you told me about. And are you seeing a decrease in the number of cases that you're, that you're encountering overall? Your call volumes down, or are they back to normal, or what's going on in that part of the world?
Our call volume's back to normal. We were down pretty much in February, March, April, but we're back seeing about 300 transports a day.
Oh, okay, got it. Okay, hang on for 1 second. I just wanted to reply to an email that I'm getting about the people that are providing our CE. But okay, well, listen, just great to have you on. That's all I was getting at, and so really appreciate it. We miss you, and it's great to see you.
I'll work on it and try to get here a little more often.
Okay, good. Let's see. Let's just see if we could take a few reports from around the planet here. It's 11:30. Anybody else who had to get off pretty soon that hasn't talked yet that we'd like to bring on? So I think there were a couple of people who said they had to get off. Nick, let's hear what's happening in Minneapolis, because the reports we're hearing around Minnesota anyways, and although at your city, is that things are getting busy up there as well. What can you tell us?
Yeah, it's for sure getting busier. All the ICUs are getting full, and so we're starting to play musical chairs again with regard to where we can put our patients. I don't think it's quite the surge that North Dakota or Wisconsin are seeing, but we're starting to feel it again.
All right, got it. And otherwise, everything else is going okay. What about the ketamine issues in your neck of the woods? Anything popping up new? I know the reporters were digging around again.
Yeah, the reporters are still interested. I don't have any real updates though. We'd love to know when these stories are going to air, when whenever there's going to be a new article. I'm really excited to hear this webinar is coming out 2 Fridays from now. I look forward to listening into that. And, from a very local perspective, I really appreciate the support from the Eagles, NAEMSP, ASAP, all the national organizations as we continue to discuss these sort of contentious issues.
Okay, good. All right, well, great. Well, best to you and the rest of the family. And let's, unless there's something else, I guess I will move on. I do want to hear, so there's someone here I did want to hear from real quick. Well, Ken Shepke, are you there by any chance? Are you around, Ken?
Yeah, I'm here.
Yeah, can you give me a report from the state of Florida? You guys do a really good job of tracking what's going on statewide, and it's the most unstable peninsula in the world, right? Politically.
Absolutely.
So yeah.
we've been in a flat plateau for months, and but just in the last 1 week, we're seeing some slow rise in hospitalizations. We've been hovering statewide. Just to give you perspective, we were about 10,200 hospitalizations, including both ICU and non-ICU, at the end of July statewide. And we dropped all the way down, that 80% down to 2,200, 2,300 range. And we've been hovering there for 2 months straight. Well, now we're just about 2,500, which is, so this last 1 week, we've definitely seen an increase of maybe 8% in our hospitalizations. Our percent positivity has been in the 3 to 4% range, but now we're hovering more in the 4 to 6% range on our daily percentage positive. So it does look like we are not immune to the rise in COVID cases that we're seeing around the rest of the country, although perhaps we're not on as steep a curve as everybody else. Our transmission rate, which has, that's the, how many people each infected person transmits. When it's below 1, the pandemic starts going away. When it's above 1, it goes up. So we've been in the below 1 for a couple months. But just recently, we've been 1.01, 1.02, so just barely above 1, which is why we're seeing this slow but steady rise. The hospitals are reporting that they are seeing more cases, but they tend to be less sick people. And that's probably because we're seeing a younger age group. A lot of the college kids, like I've reported before, don't seem to be as diligent on the various public health measures, especially after a football game. They go out to their bars and there's no, I think opening the bars and the college crew kids is one of the things. So what I'm really worried about is the upcoming holidays, when that younger, although less diligent on public health, but also less likely to crowd our hospitals, when that population comes home to hang with their older parents and grandparents, or when it gets even a little further into the winter, when our northeastern snowbirds start traveling down from those higher propensity areas, I'm a little worried about what Florida's going to look like, because we're already starting to see a slow but steady rise now.
Okay, got it. Hey, just wanted to make sure you saw the presentation you did yesterday, or at least you helped me with, right? So congratulations on that that talk. We're going to try to present it next week here on the Eagles, just so you're aware, as you may have heard earlier.
Great.
So that's good.
Thanks, Paul.
And tell Scott and Emma sent me a nice note about it. And so make sure Scott knows about it as well. So, okay. So, all righty. Let's move on. Let's see. I'd like to, if you don't mind, Terry Valenzuela, I haven't talked to you for a while. Anything to report from down in the land of the University of Arizona and Tucson?
I checked the COVID-19 tracking project, and we're clearly starting a resurgence. U of A, and it's done a particularly good job, though, in controlling it among the students. And I think it's because there's been a close partnership between the university and the county and the state and the city of Tucson. So hopeful locally, but I heard from my friends at University Hospital that they're doubling up on a lot of things and starting to see more people in the ED.
Okay, got it. And Libby, let me see, are you on your way down, hopefully, out there in Honolulu and the rest of Oahu?
Thankfully, Hawaii's numbers have remained low. The scary thing is that we reopened for travel and people can take a single test 72 hours prior and arrive in the state. Horrible plan. We didn't have capacity for the second one, and the business interest kind of won out over common sense and science. So we're kind of expecting our numbers to start going up. Tiny little island of Lanai has an outbreak with 80 people. And on the Big Island, they're having a couple of clusters and outbreaks. Interestingly, it's on the Pacific Island population. So
Yeah.
we're
Interesting.
watching.
So 80 people in Lanai, even though there's only 20 people living there, right?
Yeah, that's what it feels like. But 80 people on the tiny little island of Lanai, it's frightening, because if any of them get sick, that means that's a medevac flight over to Honolulu.
Yeah, exactly. Or you could take a boat ride over to Lahaina, right? Get a drink before you go to the hospital. All right. Well, thanks. And you're doing well yourself. Everybody doing okay there?
Yeah, if anybody ever offers you a job as the state director of health, don't take it. It's a horrible suck of a job.
Yeah, that's what I'm hearing from every state director that I know. It just, I can't, you got to see some of the, I think some of the news media were showing, like the health director in Illinois is breaking down, talking about the people that had died, and then you get, of course, hammered, right? Are you getting hammered or getting death threats or anything like that for wanting to impose some more restrictions?
So far, no, but yeah, it's not a fun job.
Yeah, I'm sorry to hear that. So, but thank you. But we couldn't have a better person in there than you. So thank you so much for the work that you're doing there. Okay.
Thank you.
All right, let's jump over. Just randomly, let me go over and talk to Chuck Burnell, just because we haven't talked to him for a while. And Chuck, what's happening throughout Louisiana and Texas with your group, Acadian?
Well, we're actually holding our own with the group. Same PPE in place statewide. We've had our little upticks. And besides politics and a lot of ads, nothing else really significantly new going on except a little bit of misbehaving. And actually, I've been out of the state for the last 2 weeks, so I'm coming back in and trying to catch up on the news myself. So,
okay, good. Okay, good. Hey, Peter, Antebby, if you don't mind, I'm going to jump over to you. And you had some presentations today that you got, and can you give us a kind of a quick wrap up on what we heard there? I thought that was interesting. Maybe we could do a more formal presentation in a couple of weeks.
Yeah, absolutely. So Mike Perlmutter is a paramedic, been a paramedic for 9 years up in with Mark Colorado at North Memorial. And he essentially, now he's in medical school, third-year medical student. He's the one who's done that. He was on our ketamine seizure paper with us. So great guy, very academic mind. And he essentially did a study recently for using nitro. I'm just trying to pull up the study real quick in front of me so I can have the exact data. But he actually just published a study using nitro, IV nitro for acute pulmonary edema. And, in the past, the studies have shown using 1 to 2 milligrams of nitro had a significant effect. They actually had 47 patients and they gave 400 micrograms of nitro with an SBP of 120. And they had 75% of those patients who had severe respiratory distress and acute pulmonary edema received either 1 or 2 doses of an IV bolus of IV nitro, and the outcomes were really very good for this small number. None of them required intubation, and the only patient who had a low blood pressure, it self-resolved within about 3 minutes, knowing that the half-life is very short for nitro. And so we had some good conversation and discussion on our Florida call right before Eagles as to whether or not this type of protocol should be implemented. And one of our medical directors in the northern part of Florida, Kim Landry, who runs a lot of services, made a great comment in that he sees at least 4 to 5 cases a month where his medics get to a patient who's in severe distress, and rather than going into down this nitro path, they end up down the RSI path, and they see the hypertension, they hear the crackles. It's kind of a classic picture that they end up getting RSI, and so this is really a nice opener. And I know Rob Dixon in Texas also has a similar study, so I want to throw it out to the group as to whether or not anyone else is doing this. And I know Amal Matu spoke on this morning at ACEP. So that's it from here, and I'd love to hear any further discussion.
Anybody else can contribute in on that or have experience with the IV nitro?
Yes, Portland, we've implemented IV nitro 1 to 2 milligram doses a year and a half ago. I have about 5 to 10 cases of success with that dose right now. No hypotension. We were very aggressive with CPAP, and we're also RSI capable. Our RSI went down markedly, actually over 90% in that group once we started using CPAP and then nitro. So we're not intubating our CHFers, assuming they could figure out what CHF versus something else.
Well, and then anybody else have any experience with this before I move on? If not, I just wanted to make a mention. I mentioned this on the phone call this morning, is that it's interesting that you brought this up. And I think that everybody thinks of nitro as being purely this afterload reducer, both particularly preload, but also afterload reducer. Yeah, I think it may even be more complicated than that. Not complicated, but more complex than that. And so, for example, we were doing some stuff in the laboratory up in Minneapolis with Demetrius Yiannopoulos. And one of the things we were looking at, we were adding to our dosage of various things that we were giving for persons who had been down for quite a while, in this case, laboratory animals. We found that using nitride, nitroprusside, was actually somewhat useful. And that I started looking in the literature more and more, and there are a lot of incredible, interesting, by the way, we think it works because it helped with the microcirculation. That's where it works there, enhancing it in the heart muscle itself. And there's some issues that there's a lot of good basic science lab stuff to point that out. But the other thing I thought was interesting is I was looking through the literature, I found these anecdotes coming up where that people had actually given nitroglycerin, particularly, let's say, after ROSC, and they were hypotensive, and or people with EMD, so to speak, or is what we call it, whatever they call it, PEA nowadays. They found out that those folks actually did better after getting some nitroglycerin. And so there was like a paradoxical effect because they were hypotensive or you couldn't find their pulses or whatever. And this actually enhanced cardiac function. So there may be more to it than meets the eye. And that's sort of interesting. So I hope we explore this a little bit more. So, and I'll try to find you those articles, Peter. And by the way, to talk to Michael again, he should get a hold of Demetrius for that reason, as I just mentioned. Okay. Hey, since
Paul, and sorry, just real quick, I put the 2 studies in the chat for anyone to get. I have the full study in one, and then just a link to the second one.
Yeah. Hey, so listen, I was going to say, I did want to make sure I repeat to all of you that if you're looking for the CME thing, and then it got sent as an email out to everybody from Jim Augustine. And then again, the number for those who are going to hop off the call and get right on that, if you got it and you've been doing it, faithfully, so to speak, every week, it's 11938. 11938 was the number for today. Okay. So we're moving on to the hour. RJ, haven't talked to you and talking about Minneapolis area and working with Unopolis. What's the latest up there? RJ, can you hear me in St. Paul?
Yeah, I got you. We're still working on mobile ECMO. The truck is getting ready, and we should be able to deploy that next few weeks. So that's what we're doing.
Okay, cool. And then I heard that a little bit that the arrest trial is under review right now, and that would be very cool. Maybe we can get you to report it, or even get Demetrius on, or Tom Ofterheide sometime to tell us a little about that's, maybe all of you. But I think that's great that you're out there helping out. So you're doing well.
By the way, Demetrius never rests. Both he and Jason Bartos have recognized the fact that when people die on ECMO, they're from refractory defib, they're dying brain deaths, not cardiac deaths. And so more and more efforts, including nitroprusside and also supercooling.
Yeah.
That's all on the front burner here.
Yeah, it's really interesting. And they're even going to take cardiac cath to the field from what I heard next. Just getting out of control, you guys. No, but it's so cool. I wrote about it yesterday in an editorial for Critical Care. So, and it refers to some of the stuff you're doing up there. So I think it's great. Hey, so anything else you can report, RJ? Is that pretty much it?
No, that's it.
Okay, thanks a lot. Hey, Rob Holman, if you don't mind, tell us a little bit about what you found out about mask wearing up there in Washington, D.C. Yeah.
Yeah, well, I sent to Paul a Washington Post article that showed it was citing, I forget where their site was, their citation was from, but it showed a self-reported surveys in various locations, states and whatnot, that in the district, if you knew somebody with COVID versus how often you actually wear your mask. And a bit self-serving, I think that's why the Post published it, is because DC was had the highest rate of wearing a mask and coordinated with the lowest rate of knowing someone who was infected. And so you can look at your state. It also divides by region. And so, Paul, if you want to send that around, that'd be great. It's kind of an
if you don't mind, send it to Jim Augustine.
Yeah.
It circulates around. All right.
Okay.
He's great at that. Jim, hey, anything new to add? Are you still on with us by any chance, Jim Augustine? And if so, you gave a lot of the report up front, but anything else new if you're there still? I think he had to get off because of stuff he was doing. And I think that's why he gave the report early on. Okay, I just want to double check. But anyway, send it to Jim. He'll take care of it for you. I do want to hear from, who was it I was just wanting to hear from here? So we can, Scott, hey, Gilmore, anything new happening at your end in St. Louis while I'm searching around for the person I wanted to, George Hatch. George, get ready, okay? So, but anything happening in St. Louis there, Scott? Anything new to report?
Nothing really new. We're on track to have the worst homicide rate in 25 years for the city just because of the violence, and COVID's doing wonders for us as well, with parts of the state having 70% positivity rates on their testing.
Okay, got it. All right, well, let's watch that. It sounds like it's, and then Glenn, are you saying that you were on the rise again up there in New York? Is that still continuing?
Yes, good afternoon. Call volume still remains pretty low, 15% below. Our hospital capacity is about 80 to 82%, depending on the day. This past weekend, we had 40 shootings, I think with 3 fatalities. So that's going up. Interestingly, NYU just reported something. You may have seen it, New York University's healthcare network. Just on their hospitals, they found that the death rate during the peak of an admitted COVID patient was 25%. You probably saw More recently now, it is actually about 8% they're reporting. So they're citing that maybe the care is better, they're identifying certain things, maybe they're just not tubing people as often, but I thought that was interesting.
Okay. Again, I've said this before and I'll probably repeat it later, is that there are people who are out there burning their masks. You know, it's kind of like, I don't know if that's some kind of symbolic thing or whatever. And it's my right as an American to have freedom, do whatever I want. But that'd be kind of like I'm free to murder somebody else, or I'm free to be a drunk driver, because it's the American way, and we can do whatever we want. And so the point is that COVID affects other people, and you not wearing your seatbelt, yeah, it might affect you, but drunk driving, for example, or murdering somebody, there's a limit to what freedoms that we should have, so to speak. And it's the freedom for other people as well. So just make sure we use the right analogies as we get out there, and especially help our lawmakers and our politicians and officials understand that this is something that impacts other people when they're not wearing masks or doing things, social distancing and so on. So, all right.
Paul, can I comment on that? It's a great line, because one of the things bantied about was this recent study from the CDC that was taken out of context about so many people that were wearing masks got sick. And I think we have to understand that masks have different roles. Some masks are designed to keep contamination in, some are designed to keep contamination out, and some are designed to do both. And these cloth masks that the CDC has been pushing are designed to keep contamination in. Their ability to prevent you from contracting the disease from someone that you're standing next to who is not wearing a mask is limited. So you wear the mask offers you personally, depending on how it's designed, a little bit of protection, maybe great protection, depending on the type of mask you get. But by and large, people using relatively low quality masks are really more designed to keep the droplets in than to prevent you from getting infected. So it's about protecting others than yourself. So that's poorly understood sometimes.
Yeah. So that's why I wanted to keep reiterating, because it's in West Palm Beach, I think, especially, you've had such protests there. I think that's something you need to make sure the chief knows there, so he could pass it on to the mayor and the council members, because they have been very supportive. I thought the commissioners, there.
Masks are mandatory in Palm Beach County, and our COVID rates dropped precipitously after they mandated that.
But since there are people fighting that, reinforce that and make sure you get those perspectives to them. I was thinking about calling the chief myself, as a follow-up to last week's meeting. So, that's it. I'm Paul Pepe, and I approve this message, right? So are you guys going to be tired of hearing that one? So we'll see. Maybe in a week or so we can get past that.
I expect it to stop November 4th.
Okay, I hope so. I thought COVID was going to stop on November 4th. You won't hear anything more about it then, right? So, all right. So, hey, Roth, outside of the fact that the Steelers are 6-0 now, or something ridiculous like that, I should say that we should keep in mind that. Oops, sorry about this thing here. We're about a year out from your shooting there, so. Anything to report from that end? Anything going on there with respect to that?
Yeah, this is our 2nd year anniversary of the Tree of Life shooting. And first of all, I want to thank the Eagles. I got so many emails of support from the Eagles group, and I really appreciate that. There's going to be some small ceremonies today, but there still are lingering wounds, both physical and emotional. And we still have to deal with that.
Has anybody taken any actions there, either legislatively or anything going on or is it just like mental health issues? Just kind of curious, or is it just going to be one of those things where we got to have our guns to protect ourselves or whatever? Has anything changed along those lines in response to that?
Yeah, lots of money has been donated to try and deal with the mental health of our providers. It's just sort of getting going now. It takes a long time. As you know, providers just don't like to seek help.
Yeah,
right. We're trying to get a first responder specific place for them to go. So,
yeah. Okay, well, that's interesting then. And then that's why this issue that's coming up tonight, as I've been learning about the theater of war thing and working with them, this guy that I told you did 1,500, live performances for hundreds of thousands of people, usually military. He said the people who are least open to the thing are the most resistant, are the ones that probably need it the most. So it's an interesting quandary from that point of view. So good. Anything else you can report from Pittsburgh besides the Steelers?
That's the most important thing.
Yeah, of course.
With respect to COVID, we've turned the corner, but we made a left instead of a right. And we look like everyone else who just reported. Increase in community numbers, increase in hospital numbers. Our providers are staying safe.
Okay, good. I'm glad to hear that then. Okay, so let's see. Is there anybody, it's getting close to wrapping up. Anybody want to throw, that I haven't called upon yet, want to throw anything into their hat in the ring here to talk about anything? Anybody want to mention anything from their area?
Paul, I have one more thing if no one's going to talk.
Okay. Oh, Peter, you asked something else? Okay, go ahead.
I just wanted to follow up on the return to work. We're starting to kind of get down to the final stages of our return to work policy. So all the people who responded, I saw the thing that Mark and Stein sent back to us today as a review, but we are going towards a policy of doing testing on those people. We have a lot of people who are still having residual symptoms. So if you haven't filled out that initial email or the Eagle survey, please do that so I can see what you're doing in your neck of the woods.
Okay, got it. So I'm going to quickly look at my own emails here today because I don't see if there's anything else I was going to cover. If not, I'll just give you highlights of what we're going to do hopefully next week. Let me see under my sent information. But one of the things is that I think if you can help out with that and do maybe a special section on pediatrics, Peter, I'd like to do a review of the new ILCOR and American Heart Association guidelines came out. And I heard it was just, what I heard, it was just, what's the word I'm looking for? It's somewhat disappointing from a lot of the practitioners out there, especially in Europe. And and I understand that you have some issues as well when you look at it. So I just wanted to make sure, if you don't mind, maybe bringing some of those things out. Not necessarily that we're right, but we probably need to, go over some of those things. So I just wanted to give everybody a heads up. That's what we're going to do. And is there anybody else that might on the phone want to know or get questions or something answered from the CDC when we meet with them Thursday? We can probably try to talk to them about that. And then also next week or next time I try to set up this meeting, we'll try to get people in from Europe, further people from Europe, because they are really getting hammered. I had a long talk with Pierre Carly, not only about these guidelines, because he's the head of the French Resuscitation Committee, but also in terms of how they're getting hit hard there. So that kind of thing. I'm going to try to also get help Michael Osterholm back to tell us about what the world, since we're in the World Series, I want to hear about the World Seriousness Watch. In other words, I want to see what he thinks, what our inning is right now. I think we went from the third inning back to the second inning, the way things are going right now. Again, you got the emails. Join us on the Theater of War tonight at ASAP. And I will continue. And by the way, Julian Maldonado, I just want to say thank you again for you and Chief Clarkson for setting this up and for being prepared. If you don't mind, if you could take a look at all the, what's the comments? What do you call those things there? The chat. I wanted to see how many people are looking at Thursday versus Friday for this meeting. And George, I promised to get to you. So anything new happening in your world? George
No,
Hatch?
sir. Yes, sir. I think the only thing that I would share with the group is all of the accreditors, and I don't care if that's a medical school accreditor or a programmatic accreditor like KHEP for the paramedic programs, are looking at ways to conduct virtual site visits. So that seems to be a tool in the toolbox that we're all going to be using. We've had one successfully launched and hopefully have a second one this week. So it's going to be one of our ways forward, I think.
Okay, got it. Thanks a lot then. Appreciate that. And then, hey, I saw Ray Fowler joined us. So Ray, thank you. How was the meeting? Didn't you enjoy it? No, thanks for getting on at the last minute.
Yeah, thank you. Tuesday mornings are our EMS fellow lectures.
We were talking today about switching over to maybe Thursday or Friday. So just so you know, okay, or at least temporarily. Yeah. So go ahead.
This is the admissions committee season, which is a Thursday afternoon commitment, but I'll get in as often as I can. This is great stuff, Paul, and everybody tune into the new NAMSP abstracts that just came out. Look them over. There's a whole bunch of great stuff in there.
Yeah, exactly. So yeah, I'm looking for it. We got about 3 or 4 that we're going to be presenting here.
Yeah, I think I counted 4 with your name in it, Paul.
Yeah. So that, and actually we got 6 coming out in critical for society critical care medicine. So it's been a productive year. It's been really good. So, all right. Well, listen, anybody else, anything report by Doug? I think, or Doug, are you still on? Anything new report from your end of the planet? Doug Swanson, I don't know if you got, maybe Doug's gotten off. I think a lot of people are dropping off. Well, look, we're at that point. So again, for me to say, welcome back, my friends, to the show that never ends. And we'll see you next Tuesday, if not before. And pay attention, because I may put us on even this week on Thursday or Friday, okay? So we'll see how that works out, and we'll give it a try, okay? So thank you very much. Anybody else have any final parting comments? Julian, anything from your end?
No, I'll take a look and see what's better as far as Thursday or Friday.
Okay, good. That's excellent. And then really appreciate your help, etc. And just so you know that the Journal of the American College of Emergency Physicians is going to put out a very nice little, salute to General Craig Manifold. And so I can't wait to see that, and just so great. And we appreciate how much you guys did for us when we came and visited for the memorials and so on. Okay. All righty. Well, listen, thank you, everybody. See you next week, if not before. Okay. Take care.
Hi, everyone. Thanks, Paul.
Okay. Thank you. Hope this was useful for you.
Thanks, Paul. Enjoyed it.
Okay, good.
Thanks, Paul.